Hello, everyone. Our today's presentation, which Shveta and I will be co-presenting, is about one of our recent studies about incorporating social and behavior determinants of health into mortality prediction. And the data from social and behavior determinants of health was coming from the unstructured data from clinical notes in electronic health record. So this is our agenda for today. We will start with a quick background about ourselves and also about the Hive Lab, which is the place that we are working as research assistants, and also the study was conducted there. Then we will touch on large language models and their application in healthcare, since this study and also a lot of other projects that are currently going on in our lab, they are revolving around large language models. And afterwards, we will continue with the social and behavior determinants of health study, the methodology and findings, and then we will wrap it up. Okay, before diving deeper into the study itself, here's a little bit of background. My name is Somayeh. I'm a Master of Health Informatics student at Institute for Health Policy Management and Evaluation, IHPME for short, at Dalla Lana School of Public Health, University of Toronto. I'm also a pharmacist by background, and I started working at Hive Lab in December 2022. And since then, I have been working on different projects. I will be touching on some of the projects today. Today, I will talk about, as I mentioned, one of our projects, which was about incorporating social and behavior determinants of health into outcome research, which is still an ongoing project. Which is still an ongoing project. We completed the phase 1 of the study in April 2023, where we submitted the results into IEEE conference, and we got accepted. So we are going to present the results in IEEE conference next month in Sydney, Australia. And also, we did a poster presentation about this study at the Research and Impact Day at IHPME. So,
thank you. So like Somayeh, I'm also a Master of Health Informatics student, and my name is Shveta. And I'm co-leading this project with Somayeh. So we're really trying to look at social behavioral determinants of health and EHR clinical note data, and how the social behavioral determinants of health can be found in the clinical notes to predict outcomes for patients. And we're excited to be here today.
This is the website for Hive Lab. I also included the URL, so we will be happy if you could have a chance to just check the website. That would be amazing. And so the Hive Lab, which stands for Health Informatics Visualization and Equity Lab, it was established in September 2022 by Dr. Zara Shakeri at IHPME Dalla Lana School of Public Health. And basically, it's working on the interface of artificial intelligence, machine learning, and public health, and trying to integrate data across different sources and scales to develop novel methods and open source tools to promote health not only at individual level, but also population health level. Currently, we have different projects, but I would say 5 of them are about leveraging large language models. That's why I will touch on this topic later in the presentation. So this slide shows highlights of Hive Lab projects using large language model. The first one is the continuation of the study that I'm presenting today. As I mentioned, we completed phase 1, but we are working on phase 2 of the project, and we are aiming at extending the scope by increasing the sample size, and also by using large language models to extract the data from unstructured format from electronic health records. The second project that I'm also leading is the diabetes misinformation and stigma evaluation tool. It's a really interesting project. We are trying to scrape data from across the web, including social media and patients forum and online surveys, And we are trying to provide patients or even healthcare professionals with advanced analytics and visualizations regarding stigmatized content or misinformation, and also the sentiment behind the content. We also included a chatbot or virtual assistant into the tool. So like patients, they can go and they can check the chatbot and check if a certain piece of text or like information, it contains misinformation or not. The third project is our UNICEF project. It's also about understanding the potential of predictive models in preventing school dropouts. So this exciting collaboration with UNICEF aims to develop a tool. We name it Early Warning System. And we want to know about students that are at risk of leaving school or schools with high dropout rates. And the ultimate goal of the project is to help countries retain more students and ensure all children have access to education. The fourth project is, the name is AMT versus large language model. So, labeling the data to train the machine learning models, it's really like expensive and also resource intensive, time intensive. So in this project, we're comparing the performance of large language models in labeling data compared to Amazon Mechanical Turk. So to see if we can leverage large language models to label the data, and that would be like easier and faster and less costly. And the last one is AI-supported hospital system project, or we call it Toronto STAR project. And this project is all about this large data set. And it is a patient-reported experience on Canadian healthcare system. So by using the cutting-edge technology of artificial intelligence, we're aiming at finding the gaps because we have access to patients' experience and what they reported. So we are trying to fill in the gaps and provide them with better healthcare experience, and also to address misinformation. So a little bit about large language models. So they emerged around 2018 and consisted of neural networks with many parameters, typically billions or even more, trained on large quantities of unlabeled text. They made like really advancement in the field of natural language processing. And they have the ability to generate human-like text and also answer questions. And they have shifted the focus of natural language processing studies from the previous paradigm of like using supervised learning for like labeled data for training machine learning algorithm. Large language models can perform various tasks with zero or even minimal prompts. We have two broad categories of large language models, general purpose and fine-tuned models. General purpose, as the name is also intuitive, they excel at wide range of tasks, and they haven't been trained on a specific data set for doing a specific job. And in contrast, fine-tuned models, they are pre-trained models that were further trained on a specific data set, for example, on a clinical or medical corpus. So they can cater to a particular domain and do specific tasks more effectively. For example, a couple of large language models are, as I mentioned, explicitly trained on clinical and medical nodes, and I will explain about them in a bit. So regarding large general-purpose large language models, probably GPT 3.5, also known as ChatGPT, is the most famous one. We have, I'm sure that we all have used it, and it was launched in November 2022 by OpenAI in the US, and really has taken the world by storm. Its user grew even faster than the last record of TikTok, reaching 100 million users in less than 2 months, and after its introduction to the market. So ChatGPT is powered by a generative pre-trained transformer, which is a general-purpose large language model trained on 175 billion parameters. And the new product of OpenAI company is GPT-4. It's the newest version, and it has been trained on a bigger corpus of data. And the main difference is that it is a multimodal large language model. It means that it can accept input of images and also text, and then it can provide us with output of human-like text. The interesting thing is that while these GPT models, they haven't been trained on clinical or medical nodes, and they are general purpose, but many studies have shown that actually they're doing really well at doing different tasks, responding to medical questions. For example, in a study which was performed by Nori and colleagues in 2023, they showed that GPT-4 it exceeded all the 3 steps of USMLE exam, which is the United States medical licensing exam. So, and there are also many more articles. I just mentioned one of them. In this study by Nori and colleagues, they even showed that GPT-4, of course, it outperformed GPT 3.5, but also it was doing even better than MedPalm, which is a fine-tuned model trained on medical notes and clinical data. I mentioned that there are 2 different types of, 2 different broad categories of large language models. The second one is fine-tuned models. And these are the most famous one coming in the article, but there are many more. The first one that I mentioned here is Gatatron, and it was developed by University of Florida, and is a large clinical language model trained on more than 90 billion parameters. And leveraged for doing downstream natural language processing tasks, such as medical question answering and also natural language inference. The second one is MedPalm and also MedPalm 2. They were developed by Google, and they are large language model designed to provide high-quality answers to medical questions. The third one is BERT. It was also developed by Google. It is Medical BERT, and it is the fine-tuned model of BERT. Both of them, they were developed by Google. And there are large language models trained on structured electronic health record data of more than 25 million patients. And the last one is Clinical Camel, which is an ongoing project by UHN here in Canada. This large language model is a fine-tuned version of Llama, which is a large language model which was trained on 30 billion parameters, but they fine-tuned it on 50,000 public chat records along with 50,000 synthetic chat records. So about use cases of large language models in healthcare, numerous studies have already shown the promising applications of these large language models in healthcare. For example, they can aid in creating discharge summary, and also they can provide clinical decision support. They can facilitate medical research by formulating the research question and also drafting the protocol of study. They can also answer medical questions, and they can serve as an interactive encyclopedia for medical education. They have shown potentials in the data extraction as well, which is really interesting, especially for extracting data from unstructured format, and which we also leverage for this study. So I just wanted to quickly mention something about one of our ongoing studies. I mentioned about this project that we are working on, misinformation and stigma on diabetes. So we did a case study. We scraped data from different patient forums, Canadian patient forums. So for this case study, we selected 2 forums, and from them we chose 25 threads and a total of like almost 200 comments. And then we wanted to see how accurate large language models in our study, ChatGPT as a general purpose large language model, how accurate it is versus clinical camel, which is considered as a fine-tuned model compared to like domain expert opinion. And the result was really interesting. Also, ChatGPT is a general purpose model, but it was doing really good. And we witnessed a high agreement, overall agreement between ChatGPT, 91%, with domain experts labeling versus only 78% for clinical camel. And yeah, we also, you can see the breakdown of agreement and disagreement in the table. When it came to the comments that domain experts labeled as not having misinformation, we had 100% agreement with clinical camel. But when it came to those comments that like domain experts labeled as having misinformation, there were only 30% agreement with clinical camel. But you can see that the agreement is higher with ChatGPT. So this long introduction brings us to the study of social and behavior determinants of health. Here is the poster we presented lately at the Research and Impact Day at IHPME. So just to give you a big picture, because we will dive deeper into details in future slides, social and behavior determinants of health have shown to have greater influence on health, even more than genetic factors and access to healthcare services. In this study, we wanted to evaluate the importance of mental health condition or mental health status of patients as one example of social and behavior determinants of health on mortality prediction in 1,058 ICU admitted patients. So various machine learning models were developed and tested on raw clinical data and also contextually enriched mental health data. And the best performing model was selected, showing that mortality prediction can benefit from incorporating unstructured data containing social and behavior determinants of health in our study, mental health status. And Shveta will explain our methodology and finding in the following slides later. So what are social and behavior determinants of health? This is the WHO definition. They are non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, and age, and affecting various health, functioning, and quality of life outcomes. Some examples of social and behavior determinants of health are like access to insurance, education, employment, and also mental health status, even the neighborhood that you're living. For example, it's proven that people with higher level of education, they are more likely to be healthier and live longer. Another example is that the obesity rate is 1.5 times more in Canadian women living in lower income households compared to those women living in higher income families, putting them at higher risk for coronary artery diseases and also diabetes. So why are social and behavior determinants of health so important? Because clinical factors have limited influence on a patient's overall health outcome, accounting for only 10 to 20%. And the rest is shaping by social and behavior determinants of health. So it's a fair question to ask, if social and behavior determinants of health are so important, why aren't they considered in outcome research? Especially like in like nowadays that we have the widespread adoption of electronic health records, which has created a huge amount of clinical data, and it can be an enabling resource for training machine learning algorithm. The reason is that the information about social and behavior determinants of health usually is recorded in unstructured format, in medical notes, in patient discharge summary, which hampers access to this information. These, this unstructured data, interestingly enough, it constitute approximately 80% of the total EHR data, and still it's a challenge for us to have access to them for secondary use. Just a quick touch on the importance of mental health as one of the social and behavior determinants of health, and why we decided to choose these specific determinants to investigate its effect on mortality. So studies have shown that individuals with mental health conditions such as depression and anxiety are at higher risk of death from physical health conditions, including cardiovascular diseases and cancers. Moreover, there is a significant association between pre-existing depression and mortality. So to further explore this, we extracted information related to mental health status of patients, including like a wide variety of mental health conditions, including anxiety, depression, bipolar disorder, schizophrenia, post-traumatic stress disorder, from patients' clinical notes. We tested the predictive capability of these factors on patient mortality, which was our outcome for this study, and Shveta will explain our exact methodology and our details. Thank you.
Thank you, Somayeh. So I'll be going over the methodology and the overview of the results that we had from our study. So the data set that we used was from the Medical Information Mart for Intensive Care 3 database, and this is from MIT. And essentially, this is a database that incorporates clinical notes from the ICU intensive care unit for around 50,000 patients. And like I said, this is for critical care patients. So this database really takes into account information like lab information, vital signs, et cetera. And those variables we use to kind of predict mortality and how those variables have an influence on mortality. So when it came to data labeling, we have a research lab with a lot of interdisciplinary students. So we had like nursing students, psychology students, health informatics students like Somayeh and I, kind of going through those patient notes and looking for any signals of mental health. And we did binary labeling. So 1 indicates a sign of mental health condition, and then 0 meaning none. And we went through and read 1,058 patient records, and we assigned labeling for each record. And when it came to data processing, there might have been some missing data, or we wanted to kind of manage any form of bias that might have happened. So we standardized the numerical features by converting them into Z-scores. And we kind of did that to kind of account for any missing data that there could have been. And then when it came for model development, we used machine learning models like Logistic Regression, kernel-based support vector machines, decision tree-based random forest, XGBoost, and ExtraTrees, and then we also used KNearest Neighbors. So this is just a quick snapshot of what the data labeling process looked like. So we looked through the MIMIC database, which we all had access to, and then we read through the clinical notes, and we assessed for any signs of mental health conditions, and then we labeled them by giving a mental health label of either 0 or 1, making it binary, and then we used this information to further look at the relationship between mental health status and mortality using machine learning. So this is a quick snapshot of some of our results. And I really want to highlight, we have the different machine learning models that I mentioned previously, but we also looked at precision, recall, F1, and accuracy precision. So if you look through, the numbers here, we did see with the augmented data set that we had as a lab, we did show an increase when it came to the augmented data set, when it came to mortality prediction. The only one where we did not see that increase was with the SVM machine learning method, but with everything else there was an increase, especially with XtraTrees. And that's the machine learning model that we wanted to investigate further. So we did an AUC curve for that one. And there was the 89% AUC curve. So we really wanted to focus on XtraTrees classifier when it came to the machine learning method to really look at mortality prediction. And we have two figures from our study over here. So on the left side, like I said, the MIMIC3 database had lots of variables that could predict mortality. When we assigned binary labels to mental health, out of the 20 variables, ours ranked 13. So you can see that mental health does have, any form of mental health in clinical notes does contribute towards mortality prediction. And then on the right-hand side, you kind of see blue and red there. So if you look at mental health, which has been highlighted, the red really signals intensity of how mental health could be contributing towards mental health predictions. So it really just shows us the strength of how the variable of mental health in the clinical notes does contribute towards mortality prediction. And we will highlight like some limitations that we found in our study. So like Somayeh was saying, there is a small sample size. So this is a pilot study. So we will be building on top of this. And we do have full-time master's students, PhD students who will be continuing this study forward with the MIMIC3 database. And then we only focused on mental health for the social behavior determinants of health. As you can see through the database, there's lots of variables that can contribute towards mortality prediction. However, we did try to, we really focus on mental health and how it can be considered and how it can interact with different social behavior determinants of health. But like I said, it's a pilot study, so we will go into this further with different variables as well. And in conclusion, we really want to emphasize the importance of using machine learning models and using extracted information from clinical notes and EHRs to really predict any outcomes for patients. So like we mentioned in this presentation, generative AI models really do introduce new opportunities for extracting social behavior determinants of health from unstructured notes in clinical data. And the augmented information that we extracted from clinical notes was really a key predictor in predicting outcomes for patients. And we want to emphasize the importance of integrating health data and clinical notes into enhancing the performance of mortality prediction and really using machine learning to predict outcomes for patients. Thank you so much for listening on this Friday afternoon, and we're happy to answer any questions. Thank you.
Thanks, that was very interesting, and it was really nice to have a healthcare-themed talk today. I'm not a healthcare professional by any means, but I was very interested in the part of your talk where you spoke about how information about social and behavioral determinants of health is trapped. I assume you mean in like things like informal notes that clinicians make and things like that. Any thoughts on how we could untrap it? Sounds like useful information.
Thank you for your question. Actually, I saw a lot of articles that were working on bringing social and behavior determinants of health and even some other important information from unstructured format to structured format, like assigning some fields so that like physicians or clinicians while working on electronic health record system, they can input like they do for age or for vital signs or lab results, but it wasn't that, to the best of my knowledge, it wasn't that successful, maybe because we have these vendors for Epic and Cerner and like other electronic health record vendor. And I think maybe I'm not a technical person. Maybe it is hard to implement it, to change the whole like EHR system, the format, and then to communicate it with all the different hospitals that are using the electronic health record system. I don't know, maybe it's costly for them, or the challenge that we already have is that this documentation part of electronic health record is really a burden, a huge burden on physicians and clinicians while they want to input the data. So adding another burden, maybe they're not accepting that, but I haven't seen like incorporating them into the structured format. That would be really easier to analyze them, but to the best of my knowledge, most of them, they are in the clinical note format or in the patient discharge summary format. Yep. Yeah.
Thank you. It's absolutely fascinating, and one could imagine, given the volume of electronic health data that there are in rich countries, that you could find an awful lot about disease. My HMO uses Cerner, and it is interesting that the doctors have all read what's there, in addition to the fact that I can read what they wrote, and I can see all my clinical stuff, and it's a wonderful health maintenance thing. I'm wondering whether you've been able to figure out what, looking at mental health, what the direction of the causality is. And I'm not a doctor either, so maybe I've got this wrong. You end up in the ICR because you've had a heart attack. You've had a heart attack because you've eaten badly. And maybe you've eaten badly because you're depressed, because you have no friends, or you have no whatever. Or maybe it's the other way around, because your health was deteriorating for reasons that maybe are outside your control, you got depressed. So is it your lifestyle that led to the depression, or the depression that led to your lifestyle? What is the causality? And wouldn't you need longitudinal data and carefully done structured notes, to be able to track that, and to then say to the clinician, warning, 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 when you have this patient in for their annual physical, you should ask about, because, and then to sort of point out some notes or some test results that suggest that all is not good. Or say to the clinician, have you thought about running this test? Because there are a number of other things, if the person's depressed, that might be, we should get to the basis of this depression. Is it something physical, or is it something medical, and what should you ask about? So I'm wondering, in the absence of longitudinal data, and the fact that you're not going to get clinicians, however onerous it is, to do drop-down lists instead of unstructured notes, what would you do next to make this more valuable from a public health point of view?
Yeah, that's a very interesting question. I think the Mimic3 database that we used, it was very holistic in the sense where they had a lot of consultation notes, where they did have kind of the, what is causing the mental health issue, the patients usually talk about it, or it would explain a situation in the hospital where a patient would be talking about something, and then they'd show some mental health signals, and that's when we started labeling 0 or 1 to kind of indicate that mental health issue. And then also in the clinical notes, they did mention any vital signs, any medical history, any of the physical ailments, stuff like that. So it was more holistic in that sense. And then I think that's where I think machine learning would come in handy to kind of extract that information, because it is hard to find. Sometimes we had to dig through 20, 30 pages of notes to kind of just find some social behavior determinants of health, because the doctors aren't really asking for it, or it's not really found in the notes. So even our supervisor, Dr. Shakri, she said that that's a common problem where the doctors aren't really asking these questions to kind of extract that information in the first place, so it's hard to find. So going forward, I personally see using machine learning to extract that information, but also explicitly asking those questions so it's easier to find that information.
Well, thank you for the great presentation. So I would like to ask a little bit more about the natural language processing that went into this. So did you use like a topic model, or did you have some sort of tags, like supervised model to figure out like if somebody had mental health challenges? And then maybe related to that, so the mental health data is binary, right? Like that's how it's coded. So I was wondering if there could be a strategy to, in the future, to make it less binary, maybe like to have categorical variables in terms of acuteness or something like that.
Actually, we did the binary kind of thing, 0 and 1, but at the same time, we were thinking about the exact same thing. Probably, for example, maybe the outcome for someone who's suffering from anxiety and depression is different from someone with the schizophrenia or post-traumatic stress disorder. So when we started, we also added we had the column to mention what's the exact problem, and even, for example, some like extra information if they are provided in the note. But then we found out that because the notes were really long, like 20, some of them 20, 30 pages, and also it was really time and like labor intensive. That is why our sample size is not like that high. So we just stuck to the like binary outcome, but it's exactly what we are looking for in the like future continuation of this study, and it's really interesting. Yeah.
Yep.
So I found your talk very interesting. I was just wondering, in terms of the patient population, were they from like a similar care setting, or was it just like any, like how did you select the patient records? I'm just wondering because, you know, someone who has chronic disease plus mental health looks quite different than someone who has pregnancy and mental health conditions. Like, so was there a lot of variety in that selection of the records? And then just a secondary question is, there's a lot of challenges with data classification and health records. You had the opportunity to use the Mimic Health database, which was American. Are there learnings that you have here for us as health researchers in Canada as we try to improve on access to and analysis of health data? So those are the two questions.
Yeah, so when it came to the database that we were using, it was specific to ICU patients, so intensive care unit. So we weren't really able to look at, you know, people who are pregnant and, you know, and their mental health signals. So it was specific to them, and it was also the adult population. So over, I think it was over 16 years of age. And that's just the database, the nature of it. You do bring up a good point, like it's American database. It's very different. The healthcare system is different in the States compared to Canada. I currently don't know of any database in Canada that would kind of have that information, but this is great to know because, like you said, mental health differs for every different type of condition in healthcare, and also it's a whole different country as well. But yeah, going back to your questions, it was very specific on the adult population in ICU, you know, with the American database. But I don't know if you want to add anything or.
Just I wanted to mention, regarding the patient's background or past medical history, I know that we didn't do any like a specific task to select them, but the person who selected the data from the Mimic3, which is the bigger database, they just mentioned that they selected a sample which was like a balance between those who died in the ICU and those who didn't. And also regarding the Canadian data, so that would be really great. I don't know if I know about Gemini, but it is in the internal medicine. So because we were working in the ICU, I haven't heard about any, even most articles, they are working on Mimic3 or Mimic4, and the other data set in the UK, sorry, I forgot the name. I haven't seen any. It is really challenging to have access to data, as you know. So as far as we know, we haven't had open access to any data set for ICU admitted patients in Canada. But that's a great question. Maybe we need to look into it.
Do the doctors and patients know that their data is being pooled in a database? And also, are there any electronic health records that don't collect patient data?
Yeah, I think the Mimic3 database, it's anonymized, so there's no trace to the patient at all. I'm not entirely sure about how that information was collected. It was done on like MIT's side, and it's an open database that we just got access to. I'm not sure if Somayeh would know if there was consent. I'm assuming.
I don't know how they collected the data, but I know that it is for like doing the research. So after doing a couple of training, you need to get the certificate to know about the privacy and confidentiality and not sharing the data, although it is anonymized. But on the side of those who collected the data, I don't know if they informed the patients about collecting the data or not.
I was more thinking broadly, not specific to this database. And do you know any electronic health records that don't pool the data, like that don't collect the data?
I wouldn't know about like specifically Canadian. Do you know the Gemini database? So we know that there is a database that is available through the Temerty Faculty of Medicine and AI Institute. So they pool data from Unity Health. Oh, it's Ontario-based.
Yeah,
Okay, so Ontario is mainly adopting to Epic. So I know, if most of them are using Epic, I would assume that's where they're drawing it from, but I don't know about any limitations when it comes to like larger electronic health records that are used at hospitals.
So, well, I'm not a healthcare professional either, and that's maybe why the question might be relevant. So, how could we use this model, or how could you use this model rather in the future, maybe for like causal inference? Because my understanding is that you're testing this model as part of a broader sort of model for social and behavioral indicators, and so obviously to understand what contributes to mortality, and maybe with mental health we have certain sort of causal ideas about how that leads to mortality. But say like if there was some other factor that you found through text processing, how would the sort of the causal inference part of it work? And so how would it, like, what kinds of sort of more like real world implications follow? Is the question?
Yeah.
Yeah. Okay.
Do you want to take a stab at it? Or do you want to? Okay. So sorry, just to understand the question. So we're asking like how this would be like impactful or useful going forward in healthcare?
Yeah, especially like if you could use the same text processing model for other variables that are maybe much less clear in terms of how they contribute to mortality, but they somehow do.
Yeah. So a lot of the variables that we collected from the Mimic3 database, they're actually like vital signs or lab report, like they're explicitly asked for in the patient care history. So it's really like going back to more social behavior determinants of health, like education level, like how many people do you live with, where do you live, that kind of information. It's really hard to find in the database. So asking for that would be helpful, and finding it's already hard. So maybe explicitly asking for it could be a good direction in the future. Just healthcare, it's a new term as well, social behavior determinants of health. So asking for it, when going forward, we really want to emphasize that we don't really have to wait until, we see the end, like when it comes to mortality, we don't have to wait until that point. So really using this information and machine learning to pick up on these symptoms early on to help with intervention. It could be very useful because we do see that, extracting this information from clinical notes can lead to mortality prediction. So really using it to prevent patients from getting to the end.
Can you join me with a really big round of applause for thank you so much. Well, let me just say thanks to everybody for coming today. I really appreciate it, and I know that for us at SRI, it's really nice for the first time that we do this, to have such good turnout and such great questions, and as importantly, such great papers. So I just wanted to thank, in order, everyone who presented a paper today. Thanks very, very much for giving us your day and your time and your work. And I wanted to thank everyone in the audience for coming, and I wanted you join me and ask you to join me in thanking both the AV tech people here at Munk and the wonderful staff at SRI, Jackie and Dan and Monique and Ivana for doing all this work, putting this together. So thanks very, very much.